Welcome to CHIRPS, the clinical hair instruction, reasoning, and problem-solving program for hair loss practitioners. The CHIRPS program is part of the Donovan Hair Academy and offers hair loss practitioners with the opportunity to develop and advance their diagnostic reasoning and problem-solving skills in the area of hair loss. These modules are part of the many training programs we offer here at the Donovan Hair Academy, and they're free for practitioners around the world. These modules are geared to practitioners with some background, and so if you're brand new to hair loss, you may want to contact us for introductory training programs. Nevertheless, you may find these modules helpful, but the CHIRPS program assumes that you have some knowledge in the diagnosis and treatment of hair loss. The CHIRPS modules are part of several programs we have here at the Donovan Hair Academy. The weekly evidence-based hair podcast is another such program. Each week I highlight some important new research in the field of hair loss, and I discuss with listeners how this new information ties in to everything we've come to learn in the past. I review key diagnostic pearls and treatment tips to help practitioners improve their skills. The Evidence-Based Hair podcast is available on YouTube, and it's available wherever you enjoy listening to your podcasts. To learn more about the Donovan Hair Academy, feel free to contact my team. They are at info@donovanhairacademy.com. So what is the basis of the CHIRPS program? Well, it's really quite simple. Patients send us challenging cases, and then I answer the patient directly, and I prepare a module such as the one you're about to watch. And these modules then help educate practitioners in various key objectives. The modules then end with a multiple choice question series to make sure that the objectives have been met. And you'll find some multiple choice questions at the end of this module. If you are a patient and you'd like your question to be considered, you can submit it through our online portal. That's donovanmedical.com/CHIRPS. We don't accept emailed questions because we need all patients to submit through our formal website portal. This allows us to confirm that you've given us permission to discuss your case, show photos, show data that you've submitted to us. So we do need everyone to submit through that portal. And a reminder, these CHIRPS modules are for educational purposes, and they shouldn't be considered a substitute for medical advice. So, Module 2, a big welcome. I'd like to review 2 key objectives that we need to consider when we're treating scarring alopecia. We will review an approach to hair shedding. What are the conditions that cause hair shedding? When a patient says, "I'm shedding," we must never jump to the conclusion that this is a telogen effluvium. Telogen effluvium is a famous cause of hair shedding, but not the only cause. I would like us to be able to describe how best to combine treatments when we're addressing scarring alopecia, and to appreciate the benefits as hair loss practitioners of developing an approach which involves ruling out disease. And so when you walk into the room, you have a list of 25 conditions on your list, and your job is to rule them out as opposed to rule them in. And so that approach we'll review today, and that approach is extremely valuable and will do you extremely well in complex cases such as this. So let's take a look at our question for Module 2, and I thank this individual very much for submitting this question. We have been given permission to discuss this question. I was diagnosed with LPP, lichen planopilaris, in early January 2022. I'm receiving monthly injections and take doxycycline twice a day. My LPP is still active. In early April, I started taking 0.625 milligrams of minoxidil, oral minoxidil, and the increased shedding began 3 weeks after starting minoxidil, and it doesn't seem to be slowing down. The shed is extreme, and it's terrifying. I'm supposed to be increasing my dose soon to 1.25 milligrams, but I'm concerned. Is it normal to be going on this long? When will it stop, or will it continue at this rate? What should I do? And so it's really valuable as you listen to complex stories to develop a hair loss timeline. And we've reviewed this in the prior module, but I would just like to emphasize how valuable it is to get out a piece of paper and write the calendar: January, February, March, April, May, June, July, August, September, October, November, December, and jot down what information you're being given. It's extremely valuable. Put everything you can. And so this patient tells us in January, doxycycline was started for a diagnosis of LPP. Steroid injections have been done monthly. And in April, she started oral minoxidil and her shedding increased 3 weeks later. That's what we've been given. We don't have a lot of other information here. In fact, we don't have any other information, but that's what we've been given. And we assume that hair shedding increased a bit above normal as the diagnosis of LPP entered the scene. Many patients with LPP do shed. So you might think the question to consider here in answering this question for the patient is, why is she shedding and what should she do? And at first glance, it appears she's shedding from oral minoxidil. It's pretty normal to shed from oral minoxidil. What should she do? Maybe continue the oral minoxidil and double it. That's expected. But let's take a look at some important principles, because the key things to consider here are really, what are the diagnoses? What does the patient actually have? What information are we missing? What information do we want from the patient to really address this question and help her? And of course, we need to address those questions. Why is she shedding and what should she do? So there's some very interesting principles that we can address here through this module. So let's take a look. So to diagnose hair loss, we use the Diagnostic set, or SET. And this is a memory tool that I use, which reminds us that to diagnose hair loss, we listen to the story of the patient, we examine the patient, and we order any tests that we think are appropriate. And so here we don't have the full story, but we need the full story. When did the hair loss start? What are the symptoms that are present? Is there eyebrow and eyelash loss? Where is the hair loss occurring? What's the patient's past medical history? Does she have dry eyes, dry mouth, cough, joint pains, diarrhea, headaches? Has she had a history in the past of low iron? Does she have a history in the past of thyroid disease? What medications does she take? What medications did she stop recently? So we really want a good history, and there's no substitute for a good history. We need a good history. We need a good story here. And then we need to examine the scalp. Is there eyebrow loss, eyelash loss, frontal hair loss that would make us consider that there's frontal fibrosing alopecia? Is there central hair loss and miniaturization on trichoscopy that would prompt us to think there's some androgenetic hair loss here? Is there scaling that would fit with LPP in this patient? Or is there scaling that would also fit with seborrheic dermatitis? Is there scaling that would fit with psoriasis? Do we believe the diagnosis of lichen planopilaris? Biopsy is not the answer to a person's diagnosis. It's a key clue. But to diagnose hair loss, we combine the story with the examination with the tests. And so when someone puts down a biopsy report on the table and says, I was diagnosed with lichen planopilaris, November 13th, 2021, my feeling is that you had a biopsy report showing you had lichen planopilaris in November 2021. In order for me to say you were diagnosed with lichen planopilaris, we need the story, and we need to have an examination, and then we see if it fits with the biopsy. So a biopsy report is not the final step in diagnosing hair loss. That's really important. We diagnose hair loss with the diagnostic set. I need all three of these points to diagnose hair loss. And so one of the things in this module I'd like you to start thinking about as you're developing your skills in diagnosing hair loss is to be able to rule out conditions. And so you may think to yourself that you take a piece of paper that has all these conditions listed on the paper, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 conditions. You go in the room, you listen to the story, you examine the patient, and then you cross off these conditions. And if you go into the room and you listen to the story and you examine the patient's scalp and you say, I don't know if she has CCCA. I don't know really if she has tinea capitis. I don't know if she has alopecia areata. I don't know if she has dissecting cellulitis. Well, then you can't be confident you're diagnosing hair loss. You can be somewhat confident, and that's okay. It's okay to say, I'm pretty sure this is what you have, and I'd like you to consider doing this. And if you don't get better, then we'll consider other options. But the approach to hair loss that we need to develop as hair loss practitioners is to go into the room, listen to the story, examine the patient, and quickly cross these things off the list. And that's called ruling out disease. It doesn't take long, but we need to cross them off only if we feel we can. And so we enter the room, we apply the diagnostic set, we listen to the story, we examine the patient, we order tests that are relevant, blood tests, biopsies, trichograms, 5-day modified hair wash collections. And we rule out these conditions. We cross them off. Gone, 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 gone. And we're left with 2 diagnoses. That's what the patient has. And then we ask ourselves, does that truly make sense? It appears that the patient has lichen planopilaris and seborrheic dermatitis and androgenetic hair loss. Those are my 3 final diagnoses. If I've ruled out the other things, then that's what I'm left with. And I have to be confident that those 3 things are truly what the patient has. But that's the approach to hair loss that we really want to be developing. And so what are the diagnoses here? Well, the patient tells us there's lichen planopilaris. What we want to know in this story is there frontal fibrosing alopecia? Is there hair loss along the front? Some patients with lichen planopilaris have frontal fibrosing alopecia. Is there hair loss along the front? Is there eyebrow eyelash loss? Is there body hair loss? Is there facial papules? Is there underarm hair, pubic hair loss? Does this fit with FFA as well? Of course, we want to confirm she has LPP. Does it actually fit with LPP, or does she actually have androgenetic hair loss and the biopsy was misread? Does she have androgenetic hair loss? 40% of women by age 50 have androgenetic hair loss. And so the odds are, if you're seeing a patient, postmenopausal patient with lichen planopilaris, the odds are that there's a 50-50 chance they'll have androgenetic hair loss. And so if you see scarring alopecia patient after scarring alopecia patient after scarring alopecia patient, and you think to yourself, gee, I haven't diagnosed androgenetic hair loss for a couple of weeks or a couple of months, what it means is you're probably missing a lot of androgenetic hair loss. Because androgenetic hair loss occurs in maybe 40-50% of patients over the age of 50 or 60. So in this case, we need to know, is there FFA? Is there androgenetic hair loss? Is there a telogen effluvium? Does this patient have low iron, thyroid disease, stress, scalp disease that would cause shedding like seborrheic dermatitis, psoriasis, dermatomyositis? Has she been on crash diets? Does this patient have seborrheic dermatitis? So there are many key questions that we have in this story in terms of what is the true diagnosis. And then when she starts oral minoxidil in April and sheds, is it simply because oral minoxidil triggered a shed? Or is it because she has androgenetic hair loss as well, and we have an expected shedding phenomenon that often happens in women with androgenetic hair loss? Does she have seborrheic dermatitis that was worsened in some way by some of the treatments that she's received? So let's take a look at this in detail. But to fully answer this question, we really need the story. the examination points and some tests. So what causes shedding? Well, there's a number of conditions that cause shedding. And so when you hear a patient has shedding, when you hear someone say to you, I started oral minoxidil in April and I started really shedding 3 weeks later, your brain has to say, you started shedding. The causes of shedding are acute telogen effluvium, chronic telogen effluvium, androgenetic hair loss, seborrheic dermatitis, scarring alopecia, psoriasis, allergic contact dermatitis. Alopecia areata is on that list as well. And so the patient started oral minoxidil in April and started shedding right after. It's tempting to say that she's shedding from the oral minoxidil, and most likely that is the cause, of course. But we need to keep an open mind. And if we bias ourselves and we pigeonhole ourselves into these easy fixes for explanations, you will be right a lot of the time, but you'll be wrong often. So we have to keep a very open mind when we're diagnosing hair loss. Why is she shedding? So let's look at acute telogen effluvium. That was the top one on the list of causes of shedding. What are the causes of acute telogen effluvium? Well, I use the memory tool SEND, or the mnemonic SEND, to remember the causes of acute telogen effluvium. And they are stress and scalp diseases, endocrine diseases, nutritional issues, drugs, and internal diseases. And so this is a very helpful mnemonic to help us remember the causes of acute telogen effluvium. So let's look at the letter S, stress and scalp disease. So is stress playing a role here? We need to ask. So we need to figure that out from the story. Was there an increased amount of stress in April, or in March, or in February? Did she have an illness in February or March that then triggered shedding? Was there an illness in the family of some other member? Was there some sickness? Was there hospitalization? Was there something that gives intense stress that could also cause shedding? Scalp diseases can cause shedding, and that's the other letter S. Is there LPP that's causing this shedding? Did it just have a flare in and of itself in April? It's tempting to say the oral minoxidil is responsible for everything, but did the LPP actually suddenly increase in intensity? Did she develop an allergic contact dermatitis to something in March or April? Did she start a new shampoo? E stands for endocrine diseases. Does she have thyroid disease? Every patient with hair loss needs CBC, TSH, ferritin. Vitamin D is great to have on board as well. I think those are the essential 4. There's other tests as well, which we might want to consider. In fact, there's about 25 other tests, but those are the key 4. Does she have endocrine disease, like thyroid disease? So we need a TSH. That's the key screening test. We don't need free T4. We don't need free T3 right now. We need a TSH. And if the TSH is between 0.5 and 4, then it's really, 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 really unlikely that a thyroid condition is responsible for her shedding. That's controversial by some, but it shouldn't be controversial. It's very clear that in the hair loss world, that if your TSH is between 0.5 and 4, 3.5, it's pretty unlikely there's a thyroid issue affecting your hair. There may be a thyroid issue, but it's probably not affecting the hair. And what about N, nutritional issues? We need to know if this patient has low iron. We need to know if this patient has a low body mass index. We really want to make sure body mass indices are 19 and above. 18.5, okay, 18. Once you start getting down 18, 17.5, 16, 16.5, 15, you get shedding. And so I always measure the body mass index, which is a very easy to calculate index, where you measure the patient's weight and their height. You punch it into a calculator and you get the BMI. And so in this case, I want to know the BMI. Is the patient's weight in January a BMI of 19? And then because of the stress of having this condition, the nausea maybe that doxycycline caused, she just hasn't eaten in 3 months, and her BMI is now 16, and she's shedding because of a low BMI. So we need to think about nutritional issues. What does she take in? Do we need to be thinking about zinc ordering, selenium ordering, other micronutrients, folate, vitamin C? Do we need to be thinking about that here? We don't know. We don't have enough of the story. But this module allows us to work through some of these issues. Certainly, we want to know ferritin levels. And finally, the D stands for drugs and internal diseases. And these are the causes of acute telogen effluvium, SEND. The two drugs that are on the list of causing shedding is the oral minoxidil and steroid injections. Now, steroid injections absolutely can cause a telogen effluvium in some people. We often don't think of that, and that's unfortunate, but it can. In fact, steroid injections can sometimes cause a telogen effluvium at the site of injections. And so there's an occasional patient that has 18 injections, and then 2 months later comes back with 18 little circles of hair loss. And the doctor thinks, or the practitioner thinks, "Ooh, you now have alopecia areata." No, you have telogen effluvium from steroid injections. It's not a common phenomenon, but steroid injections are certainly on the list. Did the patient have a low amount and a low dose of steroid injections in January and February and March, and wasn't doing better, was really worried about her LPP, and told the practitioner, "I want a lot of injections, I want high doses," and has a telogen effluvium from a lot of injections in April, and that triggered shedding a month later? Was it a new practitioner that used the wrong dose? Did she go to one practitioner in March, wasn't satisfied, and went to another practitioner for more injections? Every story is possible. We've heard every story possible. Patients are really worried, and that's okay, but we need the story, and we need to be able to understand. And so what this module allows us to think about here is, when you hear this story, we can't jump to the conclusion, you got shedding from oral minoxidil. 3 weeks after starting oral minoxidil, that's classic, you have shedding from oral minoxidil. That's a bias in your diagnostic reasoning that we must not let ourselves get to too quickly. Now, most likely that's the cause here, but we need the story, we need to examine the scalp, and we need these blood tests. We need iron, we need vitamin D, we need thyroid, we need a basic CBC, we need a weight, we need a height to calculate the BMI. We need to look at the biopsy. She says she has LPP. Does it show a reduction in sebaceous glands? Am I convinced this is LPP? A lot of the times LPP biopsies come back showing perifollicular fibrosis and perifollicular inflammation at the level of the infundibulum or isthmus. And the pathologist says, consistent with LPP. Androgenetic alopecia has inflammation at the level of the isthmus and perifollicular fibrosis. And so when I see a biopsy with LPP, I really want to see information like loss of sebaceous glands, reduction in sebaceous glands, apoptosis or necrosis of follicular keratinocytes, lichenoid inflammation, mucinous fibroplasia, marked scarring, perifollicular fibrosis. So dilated eccrine glands. So these are the things that I really want to see in a biopsy. And so when I have a patient that has a biopsy, I like to see the biopsy piece of paper. I can immediately tell whether this is a quick read or whether this is a very thoughtful read. And I think it's really important as hair loss practitioners that you develop that skill. When you see a biopsy report that says, biopsy report submitted, typical features of LPP are here, including perifollicular fibrosis and infundibular inflammation, final line, signing out lichen planopilaris. That is okay. That may be lichen planopilaris. But when a pathologist really is thinking about hair loss and does a lot of hair loss cases and signs out for doctors that see a lot of hair loss cases, there's often a lot more information on the biopsy report. So keep that in mind. There's good biopsy reports and there's bad biopsy reports. The bad biopsy reports still might be right, but be able to spot them immediately. And there are templates, in case you don't know, there are templates where a pathologist says, I'm using the lichen planopilaris template. Press number 1 on my keyboard and out spits the lichen planopilaris template. So we have to be aware of that. And I'm not criticizing how work is done. But when it comes down to interpreting the biopsy report, we have to be aware of that. So my approach to treating scarring alopecia is the following, and this is a really valuable lesson. In the first 3 to 6 months, please do whatever you can to reduce shedding, reduce redness, reduce symptoms. And in the first 3 to 6 months, do whatever you can not to increase shedding, increase redness, increase symptoms. So this is my personal view on how we treat scarring alopecia. There's a wide array of different views. I'm not saying anyone is right or wrong, but this is my view, and I think that it's a really important, valuable way of approaching scarring alopecia. And so I do everything I can to bring shedding to low levels, to bring redness to low levels, normal scalp color, to bring symptoms to low levels, no itching, no burning, no pain, or low amounts of itching, low amounts of burning, low amounts of pain. And of course, to stop hair loss. And if there's something I'm about to do in the first 3 to 6 months or 9 months that's going to increase shedding, it's going to increase redness, it's going to increase symptoms, I try not to do it. I'm going to do that later. My goal right now is to shut off the inflammation, to stop this disease. And that is my goal for the first 3, 6, 9 months. And so here we have a patient who tells us she has lichen planopilaris. I'm moving here with the assumption that the biopsy is correct. She has lichen planopilaris. We don't know a lot about her story. But we have on our list of lichen planopilaris a number of treatments. And there's probably 25 treatments for lichen planopilaris. What you need to do as a practitioner is develop a comfort into putting those treatments into categories of first line, second line, and third line treatments, according to what you think, based on the evidence in the medical literature, should be considered a first line, second line, and third line treatment. And so for every disease that exists, whether it's lichen planopilaris, frontal fibrosing alopecia, androgenetic hair loss, loose anagen syndrome, Menkes deficiency, trichotillomania, you name it, there's a list that I have in my mind of first line, second line, and third line treatments. And so generally we start with first line treatments. If they don't work, we bring on board second line treatments. And if they don't work, we bring on board third line treatments. Maybe we'll keep one first line treatment and we'll use a second line treatment as well. Maybe we'll use 3 first line treatments and 1 second line treatment and 1 third line treatment because the patient really likes it because they've heard about it and they want to do that, or they come into clinic with that. But we need to realize that the treatments are categorized into first line, second line, and third line treatments. So for lichen planopilaris, the first line treatments in my mind, based on safety, affordability, ease of use, and effectiveness, all those things, safety, affordability, how cheap it is, how effective it is, would be topical steroids, steroid injections, doxycycline, hydroxychloroquine. So that is the list in my mind where we combine safety, affordability, feasibility, and effectiveness. SAFE, that's my SAFE mnemonic. If you ask me, what's the best treatment for lichen planopilaris in your opinion? It's probably cyclosporin. But I put cyclosporin in my list as a second line option because when we think about safety, affordability, feasibility, and effectiveness, it doesn't have as optimal of a score, an imaginary score in my mind, as something like steroid injections, topical steroids, doxycycline, hydroxychloroquine. Cyclosporin is a potent immunosuppressant. There are some safety concerns, high blood pressure, affecting the kidney, affecting the gingiva, causing immunosuppression, increasing the risk of skin cancers, possibly other malignancies long term, affecting electrolytes, affecting magnesium. And so when we think, and it's expensive, depending on the country you're in, it's many, many hundreds of dollars per month. So when we think about safety, affordability, feasibility, and effectiveness, this is the list that we come up with. And so our patient here is on steroid injections and doxycycline, which is wonderful. If she ends up doing really well and the disease stops and we reduce the symptoms, we reduce the redness, we reduce the shedding on steroid injections and doxycycline, then that's the treatment. If not, we bring on board more first-line treatments. And if that doesn't work, we bring on board some second-line treatments. And so when I think about a patient with LPP, and I think about this patient, I think starting steroid injections and doxycycline is wonderful. And the thing that I might consider in a patient like this, depending on the severity of the redness, severity of the inflammation, I might add clobetasol lotion a couple times a week, maybe every day, but maybe twice a week with the steroid injections, especially in itchy areas. I might add an antihistamine like cetirizine, which goes by names like Zyrtec and Reactin, a couple times a week, but that's a personal sort of decision. There's nothing wrong with starting doxycycline steroid injections. That's a really good approach. And so I'm thinking in my mind when we start treatment, I'm doing everything I can to reduce redness, reduce shedding, and reduce itching, burning, and pain. And I'm not going to do anything in my mind to increase redness, increase shedding, and increase itching, burning, and pain. And so I might consider seeing the patient back in a few months. If she's not getting better, I might add hydroxychloroquine if there's ongoing redness, ongoing symptoms, ongoing shedding. So I might add hydroxychloroquine, which goes by the trade name, for one trade name, Plaquenil. Some people know Plaquenil better. And perhaps if she's not getting better down the road, I might add low-dose naltrexone. I might add more clobetasol instead. Instead of twice a week or 3 times a week, we might use it daily or twice a day. And so there's quite a bit of leeway in thinking about these treatments. But everything I'm thinking about in these first 3 to 6 months, 9 months, is I need to stop redness, I need to stop shedding, and I need to stop symptoms. And so my approach to treating scarring alopecia is to reduce redness, reduce shedding, reduce symptoms. And I'm going to try to avoid doing anything that increases shedding, increases redness, increases symptoms. And so in my algorithm, the way I think about treating scarring alopecia, certainly I treat a large number of patients with scarring alopecia every single day, is I'm a little delayed on when I add oral minoxidil, topical minoxidil, low-level laser, PRP, anything that can stimulate shedding, anything that can irritate the scalp like topical minoxidil, rosemary oil, anything that can potentially irritate and cause redness, cause shedding. I delay that because my goal in the first 3 to 6 months, reduce shedding, reduce itching, reduce burning, reduce pain, reduce redness. I'm trying to shut off this disease. That's my goal. I view it as a dial, and I'm dialing this down to 0. So how can we reduce shedding in this patient? Well, we want to address the LPP. We want to address any telogen effluvium that's present. So we need to really ask a lot on questioning, on history. Is there any stress, low iron, thyroid problems, seborrheic dermatitis, other medications that were started or stopped, excessive use of steroid injections? Is there other causes of telogen effluvium here that are causing shedding and are causing the flare in April, May? Is there any seborrheic dermatitis that's present? Do we need to bring on board an anti-dandruff shampoo? Again, I'm doing everything I can to reduce redness, reduce shedding, reduce itching, reduce burning, reduce pain, and anti-dandruff shampoos are on that list. And so I need to ask if there's any seborrheic dermatitis here in my mind. Remember, I'm going into the room with that piece of paper with 20 diagnoses on it, and I'm crossing them off. And if I can't cross out seborrheic dermatitis, then I ask myself at the end, I notice I still have seborrheic dermatitis on this piece of paper. Am I really confident that's a diagnosis? Yes, I'm going to treat the seborrheic dermatitis. Anti-dandruff shampoos. And how do we reduce shedding? Well, we address any inflammatory issues that are present other than LPP. Is there any allergic contact dermatitis here? Is there any psoriasis here? There may be an increased risk of psoriasis. It's minor in some patients with LPP. That's controversial, but we have to be thinking that. Is there seborrheic dermatitis? Is there psoriasis? Is there allergic contact dermatitis? Is she using a brand new shampoo in March and has an allergic contact dermatitis? Allergic contact dermatitis is this type of skin allergy. Patients often develop redness on the scalp. If it's bad enough, they develop shedding. But they often develop redness on the face, on the neck, on the ears, on the back of the neck, on the chest. And so if you have a patient you're wondering about allergic contact dermatitis, and they don't have redness on the face, on the chest, on the back, or on the ears, something like that, it becomes much less likely that they have allergic contact dermatitis. But of course, if you think there's allergic contact dermatitis, or you're suspicious, you want to give them a hypoallergenic shampoo. And you may even want to ask your patch testing colleagues in dermatology to help you. So how do we reduce redness? We've talked about how we reduce shedding. How do we reduce redness? Well, we address the LPP. We address any seborrheic dermatitis that's present that causes redness. And we address these inflammatory scalp issues. So the things that cause shedding often cause redness. And how do we reduce symptoms? Well, we address the LPP. Telogen effluvium can sometimes cause symptoms. So if she's never had a blood test for ferritin and she's shedding because of low iron, we want to figure out why she has low iron and supplement with iron. And refer her to someone who can help us figure out why she has low iron if we can't figure it out. But telogen effluvium can cause increased scalp symptoms. Low iron can cause increased scalp symptoms in some patients. We want to address seborrheic dermatitis because that can cause symptoms, and we want to address any inflammatory issue as that can cause symptoms. So step one is to get things quiet. The first 3 to 6 months, and you can say 9 months if you want, is to get things quiet, to take that dial and shut it off. To take that dial that says this activity is 4 or 8, I want to get it to 0. Step 2 is to get things growing after you've got things quiet. And I think that's really important. And that's my view, but I think it's a really important principle. And so I only think about getting things growing once I've shut off the disease. So I don't think about oral minoxidil, topical minoxidil, laser, PRP in the early days of treating scarring alopecia. That's coming down the road, but I want to take that dial and shut it off. I want to be absolutely confident that a patient is not shedding because of their disease. I feel that I have a little bit of time to get these follicles growing, but I do not have that same amount of time to shut off the disease. I need to shut off the disease, and I can't waste valuable time by having a treatment on board that's now going to cause shedding. And I have to wonder to myself, are you shedding because of the treatment I just gave you, or are you shedding because your scarring alopecia is active? I want to shut off the disease, and I don't want to do anything that's going to impede my ability to shut off the disease. So this is my view, and you may decide you'd like to incorporate it as your view. You may decide that's not your view. In the first 3 to 6 months, I'd encourage you to think about doing whatever you can to reduce shedding, reduce redness, reduce symptoms. When I work with physicians, I use a lot of analogies because analogies help bring a different perspective to things, especially if you're skeptical. But if you imagine you have a beautiful garden and now you have bugs in the garden, you might say to yourself, my plants aren't growing very well. I'd like to really get a better fertilizer. Um, there's this wonderful fertilizer that I saw at the store, or I saw on an infomercial. I'd really like to fertilize these plants to get them growing. Maybe I'll get an insecticide as well, but I'm not sure. I'll ask my neighbor next week. For now, maybe I'll spray it with a mild insecticide that I used for some other plants years ago. I think the key here in that analogy is we need to use the insecticide before we use the fertilizer. We need to get rid of those bugs in the garden. You can put all the fertilizer you want on that garden, but unless we get rid of the bugs, we're not going to have the beautiful garden. So the attention has to be on the insecticide. We have to figure out what insecticide should be used for these bugs. We need to figure out how much to use, how often to use it, whether to spray it in the night or the morning, whether to spray it once a week or twice a week. Our entire effort has to be insecticide, insecticide, insecticide. We need to be Googling insecticide. We need to be going to greenhouse stores, nurseries. We have to be talking to experts. We have to be looking at the bug. We have to be taking pictures of the bug. We have to be thinking insecticide, insecticide, insecticide. Down the road in a few months, we can be thinking fertilizer, fertilizer, fertilizer when our garden is eradicated from this bug. But the attention has to be on insecticide. Same is true with scarring alopecia. Our attention in the first few months has to be on reducing inflammation. Reducing inflammation, reducing symptoms, reducing shedding. That's the goal. We need to be Googling about that. We need to be talking to experts about that. We need to be thinking about that. That's our attention. The fertilizer, the minoxidil, the PRP, the laser, there's time for that. It's coming down the road, but it's not now. And so in a patient like this, I may consider doxycycline, steroid injections. I think that's wonderful. I might consider clobetasol. I might consider cetirizine. See the patient back if they're not improving with shedding, itching, burning, redness. They're losing more hair. I might consider hydroxychloroquine. I might consider the low-dose naltrexone down the road. I might consider increasing clobetasol. I might consider increasing cetirizine. We can't go higher than twice a day doxycycline. We may not want to go higher on injections. We increase the risk of atrophy. But this is the kind of approach that I use in thinking about first line, second line, and third line treatments. And so when I have a patient with lichen planopilaris, I have this list in my mind of first line, second line treatments, third line. And so I'm beginning with first line treatments. And then I'm saying to myself, do I need to dip into the second line treatment box? Do I need to reach in there and take out a cetirizine and say to the patient, let's talk about cetirizine? Is now the time to reach in there and say, let's talk about low-dose naltrexone, cyclosporin, methotrexate, isotretinoin? We can't use isotretinoin with doxycycline. It has a rare interaction, increasing brain pressure. Is it so active that I need a short course of prednisone, a month of prednisone to kind of bridge us as we're tapering down? And so these are where I start first line treatments. Then I go into second line, and I'm a long way away from third line treatments in my mind. Now, how many treatments do we choose? Well, I really think that is a case-by-case decision. If a patient's scarring alopecia is really active, lots of inflammation, lots of patches of redness, lots of shedding, you may want to bring on board 2 treatments or 3 treatments. This patient started on doxycycline, steroid injections. That's excellent. That's a first-line treatment. Those are great options. There's nothing wrong with starting 2 treatments. If it's a patient who has really mild LPP, they don't think they've had any change in their hair for 5 years. It just so happens they have LPP on biopsy. Then you might just start clobetasol. See the patient back in 6 months and see how they're doing. So you may start 1 treatment, you may start 2, you may start 3, but My general rule is do one at a time if you think that that's not going to compromise any long-term outcome, if you don't think that that's going to cause hair loss. But if you think that, gee, if I just do one treatment, the patient might lose hair and it's going to be permanent and scarring alopecia, then maybe you'll want to do 2 or 3 things. So don't do anything that you think is going to compromise the long-term outcome. And that's challenging. That takes experience. That just takes a bit of guesswork. Clearly, doing one treatment leaves you a little bit uncertain and feeling not at ease. If you just send the patient home with topical clobetasol and they have active LPP, that might not be the best plan. Sometimes that's done, but that might not be the best plan. Because topical clobetasol maybe helps 30 to 50% of people significantly. But there's going to be a whole lot of people that aren't going to be helped just with monotherapy with topical clobetasol. So don't do anything, don't administer a treatment plan that you think has a pretty high chance the patient's going to come back with more hair loss. So you might want to do 2 things, you might want to do 3 things. But you can imagine that you probably don't want to send the patient home with 13 prescriptions. Page 1 of my prescription pad, page 2, page 3, page 4, page 5, page 6, page 7. That's silly, of course, but I use it as an example that somewhere there's a happy medium between starting 1 treatment and starting 2, or starting 3, or starting 25. There's no right or wrong answer. But certainly starting 2 or 3 treatments is not unreasonable. And so my hope in a patient is that if the shedding is increasing when the LPP starts, that we reduce it down to a pretty normal level. And that redness drops down, shedding drops down, itching, burning, and pain drops down. Now, if there's seborrheic dermatitis, I'll have an anti-dandruff shampoo on this plan. If there's low vitamin D, we'll have vitamin D in this plan. If there's low iron, we'll have iron in this plan. If there's thyroid disease, we'll probably have the patient see an endocrinologist. And then we get things growing after we've got things quiet. So that's step 2. And so that analogy is powerful to me. And that is that we think about fertilizing this garden once we've got rid of these bugs. And I think about stimulating hair growth with minoxidil, topical minoxidil, Rogaine, oral minoxidil, PRP, low-level laser, when we have got the disease under better control. And that's just my personal view on how we treat scarring alopecia, but it works for me. And it allows me to practice with this intensity that we want to turn that dial off. And I need to turn that dial off. I need that dial at 0. And I want to get to 0 as quick as I can. And I don't want to be thinking in 6 months when the patient's shedding, well, maybe they're shedding because of my low-level laser device that they started. So I like to get things quiet first, and then step 2, get things growing. And I might start one of these treatments. I might not start all 3. I like to do things one at a time so I know what's helping. But you might start low-level laser. It's a wonderful option for scarring alopecia. It's safe. It does have anti-inflammatory property. It treats androgenetic hair loss if that's present. You might start oral minoxidil. That's great. It stimulates hair growth. It helps androgenetic hair loss. It helps any telogen effluvium component that's present. So let's return to this question and see where we are at and how we can help this patient. And I thank this individual again for submitting this question. This is module number 2. I was diagnosed with LPP in early January 2022. I'm receiving monthly injections. I take doxycycline twice a day. So right now I'm feeling she's on great first-line treatments. LPP is still active. And so this is a very interesting situation because the patient's telling us she appreciates that her LPP is active. She's using a lot of language here where she appreciates that there's activity that's high or low or medium in these assessments. She's on monthly injections, so she's fortunate to be able to have a dermatologist or a clinician who is able to administer monthly injections. and sees the value of them, their first line options. And so I'm immediately feeling this patient is really under good control. She's got good care here. And in April, she was started with oral minoxidil. Nothing wrong with that. My preference, of course, is to shut the disease down first before we start oral minoxidil. She's increased shedding 3 weeks later after minoxidil. And so when she has increased shedding, I'm thinking to myself, are you shedding because of minoxidil? Are you shedding because of steroid injections? Are you shedding because of low iron? Are you shedding because of a thyroid disease? Are you shedding because of another supplement you took? Are you shedding because of stress? Are you shedding because your weight has dropped even more because of the stress of all this and your BMI is now 16? So when I hear shedding, I'm kicking into a different gear. The shed is extreme and it's terrifying. So this is a very stressful event for this patient. The word terrifying is a very powerful word. And extreme is a very powerful word. And so the words that our patients use are really important to cue in on. They're communicating with us. And we do need to pay attention to the words that our patients use. And so this patient's really scared. Supposed to be going up to 1.25 milligrams of minoxidil soon. She's concerned. What should she do? Well, what would I do for a similar situation? Well, first I'd get the story, I'd examine the scalp, and I'd get tests. I'd listen to the story more. Am I convinced this is LPP? Am I convinced there's not something else going on? Does she have eyebrow, eyelash loss? Does she have body hair loss? Does she have something else going on? Does she have chronic diarrhea that's giving a low iron and low zinc? Has she forgot to tell us about some medications? Has she forgot to tell us that she had some significant event that caused depression in 2020 or 2019 that prompted an antidepressant and it was subsequently changed to another antidepressant recently? Do we have the whole story? That's so important here. Do I have the whole story? I don't have the whole story here, so certainly I'm limited. But the key here is, do we have the full story with any patient you're seeing? Then we examine the scalp. Do we think it's LPP? Do we think there's FFA here? Do we think there's androgenetic hair loss? Do we think there's seborrheic dermatitis? Do we think there's something else going on here? I like to get things quiet before I get things growing. And so my own preference would be to delay the oral minoxidil, but in this specific case where the patient presents to me on oral minoxidil, I don't want to stop it. It's not uncommon to have shedding when we start oral minoxidil. I'm not going to buy into or pigeonhole myself into believing that it's the oral minoxidil right now. I'm 99% sure it's the oral minoxidil, but I'm not going to let myself go to 100%. There are so many causes of shedding, and we need to be humble to the fact that there is stress, low iron, thyroid disease, seborrheic dermatitis, psoriasis, weight loss, other medications, herbs, supplements, irritant contact dermatitis, allergic contact dermatitis. I need to know about those things before I push it from 99 to 100. But I'm going to continue the oral minoxidil in a patient like this because to stop my trigger hair loss, and right now what I want is stability. I want to do everything I can right now to reduce shedding, reduce symptoms, reduce itching, reduce burning, reduce pain, reduce hair loss. So I'm not stopping the oral minoxidil, but I'm not going to go up on the oral minoxidil yet. 0.625 is not an unreasonable dose. We can go up later if we want. I want to shut off the shedding first. If she's sensitive to oral minoxidil, that's okay. We can go up later at a time when it feels better. I'm going to wait. There's nothing wrong with going up. It's not considered, that's the wrong step. My preference would not be to go up. Again, I want to do everything I can to stop shedding, inflammation, and hair loss. In a situation like this, I might consider adding another first-line agent, second-line agent at some point. Maybe one of these, maybe two of them. maybe clobetasol, maybe cetirizine. We might do topical clobetasol twice a week. We might do cetirizine 3 times a week. That's not an unreasonable plan. I wouldn't do all 4 of these. I probably wouldn't do 3 of them, but I would do 1 or 2 of them. I would continue the doxycycline twice a day, continue the steroid injections, review the steroid injection dose, review if in fact there's a possibility of a telogen effluvium here. I might, if it's 5 milligrams per mil that I'm using, I might back down to 2.5 milligrams per mil if I'm going to add on clobetasol. So I might just sort of think about how I'm doing things. If we're getting atrophy, we'll know by now she's had injections in January or February, and then March, and then April. So I'm going to look for indentations for atrophy, and if there is, I'm going to back down on the steroid injections more readily. I'm going to treat any seborrheic dermatitis. I'm going to bring on board an anti-dandruff shampoo if there's any seborrheic dermatitis, yellow scale, the dilated blood vessel pattern of seborrheic dermatitis by trichoscopy. And I'm going to make sure labs have been done for CBC, TSH, ferritin, vitamin D. And I'm going to think about adding on any other tests if appropriate. I'm probably going to add a cholesterol profile if it hasn't been done, glucose, hemoglobin A1C. We know that patients with LPP are probably at slightly increased risk for metabolic syndrome, cholesterol issues, glucose issues. It's a low risk. We don't find many LPP patients with sugar issues, cholesterol issues maybe. And so in my screening, I'm going to make sure this gets done. It's not really relevant to the shedding that's happening now, but I want to make sure that before this patient leaves, in case she doesn't return again, that she's had a cholesterol profile done. There's not a lot of role here for ESR, but if the history suggests some sort of other inflammatory issue, I might order it. If she has joint pains, morning stiffness, I might order a rheumatoid factor anti-CCP. If she has chronic diarrhea, I might add a zinc. If she has dry mouth, dry eyes, dry lips, I might consider a workup for Sjogren's by ordering an extractable nuclear antigen, ENA. If we're thinking at this point, we might need methotrexate, cyclosporin. We might need something down the road. I might order creatinine and liver function tests, AST and ALT at this juncture, so that we don't have to get them yet again down the road. If I want to start a stronger systemic agent at the next appointment immediately, and I don't want any delays, I'm going to tuck it into this blood work that she's going to get done now. So I want to be thinking ahead. But if the patient does have frontal fibrosing alopecia, not only LPP, but frontal fibrosing alopecia, which is a scarring alopecia closely related to LPP, I might start a more first-line treatment for FFA, which would be dutasteride and isotretinoin. And so in this patient with shedding with LPP, I'm going to confirm she has LPP, make sure I'm 100% confident. I'm going to make sure that I'm confident she does or does not have AGA, whether she does or does not have seborrheic dermatitis, and whether she does or does not have FFA. But if she has FFA, I'm going to add dutasteride or isotretinoin. And so I see this as a dial, like a dial on the stove, or a dial on the radio, or a dial on some other electronic instrument. I was going to say a television, but we don't have dials on televisions anymore commonly. But we're taking this dial and we're turning it off. And I want to shut this to 0 as quick as possible. And I don't want anything to impede me. I don't want something that's going to cause itching to come on board. Hey, doc, I'm going to do some derma rolling or derma stamping or a derma pen. What do you think? No. I don't want that to be brought on board right now. That's going to cause redness, itching, burning, shedding. Maybe it won't, but I don't want that risk yet. Hey, doc, I'm going to use this herbal rosemary essential oil lotion on my scalp. I'd rather you not. Some of the essential oils are irritating. Give me 3 to 6 to 9 months so that I can shut off this inflammation, that I can turn that dial to zero before we start stimulating hair growth with minoxidil PRP laser. So that's my view. So I hope this module was helpful for you. We've looked at some of the causes of hair shedding. We've looked at this approach to scarring alopecia and these two objectives where we first try to shut off symptoms, itching, burning, and pain, try to shut off redness, try to shut off shedding, and then we address growth. So that's my approach to dealing with this. Again, not everyone's approach, but it's my approach, and it's a helpful way of doing things. I've talked about this general approach in the hair loss diagnostic algorithm of ruling out diseases. And so as you train your mind to think about hair loss, think of a piece of paper with 25 diagnoses on it, and you're walking into the room and you want to be able to scratch off those other diagnoses quickly. So when I see a referral and it says to me, would you please see this 14-year-old female with trichotillomania? Appreciate your assessment. I don't walk into that room with the feeling, okay, let's see how we can approach this trichotillomania. I know that we might want to refer you to a psychologist, psychiatrist. Maybe we'll try N-acetylcysteine. I've heard that other treatments can be considered. I walk into that room with 25 diagnoses on my page. And I want to make absolutely sure before I leave that room that that patient does not have lichen planopilaris, folliculitis decalvans, alopecia areata that triggered hair pulling, seborrheic dermatitis that triggered hair pulling, scabies that triggered hair pulling. I want to make sure that that patient doesn't have some other type of hair condition. And so I really approach hair loss with this view of ruling out conditions. And if I'm not confident that this patient has one of those diseases or one of those conditions that's still on my list at the end of the day, we're going to try to investigate. And so I really approach hair loss with that ruling out approach. And so I thank you again for your attention and your participation in this particular module. I'm going to leave you with some multiple choice questions that will have answers at the end that you can reflect on yourself and allow you to review whether you have met the objectives. Thank you again. Look forward to seeing you again for our next module here on CHIRPS.